development, the impacts of that for a child in terms of development, particularly movement and posture, may change. So the third point, as I've just said, is it involves disorder of movement and or posture and or motor function. And I guess a key point there is that if you have an acquired brain injury that causes a special sense disturbance but no problem with movement or posture, that does not constitute cerebral palsy by this definition. And that the problem is due to a non-progressive interference, lesion or abnormality. So those conditions that are neurodegenerative are not classified as cerebral palsy. And of course, the interference, lesion or abnormality originates in the immature brain. Now, there is some discussion about this, whether this represents the immature brain is up to 2 years of age, which is the time that most myelination is finalized in the central nervous system, or indeed some definitions use up to 5 years of age. I'd like to highlight this document on the right, which is a new version of the report from the Australian Cerebral Palsy Register, which is a good key reference for understanding cerebral palsy, and particularly its etiology and prevalence with respect to an Australian cohort. CP is common. It's the most common cause of physical disability in childhood, and recent projections suggest that's up to 2.1 per 1,000 live births. Interestingly, with this report, the last 10 years of birth reports have suggested that incidence is actually decreasing slightly. And unlike previously, and due to advances in general health and also medical advances, most young people with cerebral palsy are now living into adulthood, with 90% living past 18 years of life and 80% living past 30 years of life. So these young people will be frequent flyers in adult rehabilitation clinics. Now, despite the fact we've said that CP is defined by being a movement or posture condition, there are also very frequently associated impairments in health conditions. Most commonly, they are problems with communication and cognition, with many children having developmental disabilities or intellectual disabilities, and problems with sensation, special senses, and epilepsy being a very common comorbidity. There's also increasing evidence that pain is a frequent presentation for young people with cerebral palsy, with some studies suggesting that chronic pain occurs in up to 70% of the population. And we also see plenty of children with dysphagia, gastroesophageal reflux disease, and of course musculoskeletal deformities, which often characterize the condition. So onto the CP rehabilitation assessment. The first part of that, really, when a child comes to see me in clinic, is some review of how they've obtained the diagnosis. Bearing in mind this is often a diagnosis of a clinical diagnosis, and some degree of surveillance for common comorbidities and health conditions. So onto the diagnosis check. So very frequently, the history is suggestive or of cerebral palsy being a likely condition. The most common risk factor, or the biggest risk factor, is premature birth. But I should note here that most children with CP are not born premature. Other conditions that are associated with this are, in fact, male gender is slightly more prevalent in male gender. Also, twin births are another risk factor. Investigations aren't always necessary, but generally we find they're advisable, and an MRI after 2 years of age is often the most useful to see in the mature myelination patterns, with myelination issues being the most common, myelination disease being the most common problem. Some studies suggest that there's a relatively high misdiagnosis rate of up to 5% in one fairly recent study. You can see from these charts on the right-hand side here that were driven from the new CP register, that actually most cases of CP occur in the prenatal period. I guess that historically there was a lot of there was a feeling that most cases of CP were caused by birth asphyxia and problems during labour, but that is not the case. And so that there may be only very small suggestions that there was an event sometime during pregnancy that has caused CP, such as a intrauterine infection. And 6% of those children with CP are derived from postnatal causes, including, I guess, meningitis and other causes of acquired brain injury. The lower graph shows the timing of the diagnosis, and this is often driven by the emergence of motor phenotypes. So just over half are diagnosed within the first 12 months of life, but it's quite common, particularly with the more mild phenotypes, to see children diagnosed perhaps with differences in handedness within the first between the first year and the second year. So neuroimaging, when it's performed, often finds a finding which helps confirm a diagnosis of cerebral palsy. The most common finding is periventricular white matter, and of course you all know that during the second trimester that the periventricular white matter is a watershed area for ischemia, so changes in the cerebral blood flow during that period can end up causing damage to the corona radiata as it passes past the lateral ventricles from the cortex. And that often presents later on as gliosis. This is a T2 flare image showing some PVL and a little bit of gliosis in that right anterior horn there of the lateral ventricle. Other common findings are grey matter injuries, sometimes signs of a cerebral vascular accident, and a smaller group are of course earlier in development with cerebral malformations such as schizencephaly and lysencephaly, which represent disorders of very early neural development and neuronal migration. Another key point is that there are normal imaging findings in 13% of children with cerebral palsy. I just wanted to briefly talk about red flags, and I think this is pertinent even in the context of young people who are seen in adult rehabilitation clinics, because it can. I've recently seen a 17-year-old who has a long-standing given history of cerebral palsy, who had a degenerative episode last year and has now ended up with a new diagnosis, a new rare genetic diagnosis of a primary dystonia. So the red flags here are already in the absence of a definite risk factor or an insult. Multiple first-degree relatives with also with cerebral palsy, episodes of developmental regression, so loss of motor skills, signs including ocular abnormalities which might indicate mitochondrial disorders, other involuntary movements, ataxia, muscle atrophy and sensory loss, which also are not common with cerebral palsy. And we often use, as I'll discuss briefly later on, dopamine replacement with levodopa-carbidopa as a treatment for dystonic cerebral palsy, but for some conditions with, well, in some cases where there's an excess response to dopa replacement, that might represent a genetic condition such as dopamine responsive dystonia. So on to the rest of the CP assessment. So our physical assessment often involves a review of gait for those children who are ambulant, who are walkers, their general mobility for children who are yet to gain that skill or are unlikely to, and active and functional upper limb movements. Passive range of motion, including, of course, thinking about the spine, a neurological exam, and assessment for the type of movement disorder. And I've mentioned spasticity and dystonia here as being by far the most prevalent in our practice. So topography, simply expressed as the areas of the body that are most affected. Hemiplegia represents approximately 40% of those young people with cerebral palsy, and the other diplegia and quadriplegia and other phenotypes represent the smaller groups, triplegia being a very small percentage. I should note here that children and young people with diplegia often do have some involvement of their upper limbs. We most often see that through difficulty with fine motor activities, and a common screen for that in a school-age child might be difficulty with fasteners, either buttons or zips on the upper extremity, or perhaps fasteners and zips of lunchboxes or other school-required equipment. We also see, particularly in high school years, that children with diplegia hemiplegia, and indeed hemiplegia as well often have difficulties with their handwriting. Many of you will remember getting severe writer's cramp during your written school examinations, and perhaps since that time as well. But for a lot of our children with hemiplegia and diplegia, even where their hands work very well for them in other circumstances, their writing at volume and speed is a challenge for them, and often they need extra support in a school examination and indeed a university examination environment to allow them to achieve their academic aims. Sorry, I'll go down this way. I also just wanted to point out that the complexity of the movement and posture difficulties in cerebral palsy. One key factor here is we need to consider the age and developmental level. What should we expect? What is normal for this child's development? Now, on top of that, there's the elements that we all discuss mostly, and from a medical perspective, we're often most interested in is the movement disorder. So we'll talk a lot about spasticity and dystonia. But even removing that, children's movement with CP is often not normal. They often have difficulties with motor planning, difficulties with praxis. So that may be accounted for to some degree by their developmental level. It may be accounted for to some degree by the fact that they may have lacked the opportunity to develop that motor skill. But there are other aspects of this as well. They often have difficulty with selective motor control, that being enacting exact muscle movements at will. There's often muscle weakness. They often do have some degree of altered sensation, particularly proprioception, that may impact upon their motor activity. And as time goes on, and we'll talk a little bit about this, they often have biomechanical changes, including torsional deformities and musculoskeletal contractures, which can also impact upon movement. So spasticity and dystonia treatment is not the only problem here. I just want to highlight these three papers, which I think are very useful as a way of thinking about how pediatric practitioners think about or can think about the different movement disorders that are available, that are present in childhood. Many of these are similar but not the same as other definitions that I've seen, perhaps particularly thinking about dystonia from an adult perspective. And there are multiple similarities there though, so I think these are definitely worth a review, and I'll discuss these a little bit later as we go along. So this task force of childhood movement disorders actually classified abnormalities of movement in children, and including cerebral palsy, into three categories. There are those children who have hypertonia, so are stiff on passive movements. That's something we obviously feel on clinical examination. There are those movement disorders where there is an element of hyperkinesis, so too much movement, and that's often stuff that we see without touching the child, that we can see just there in front of us. And there are also the negative motor signs, which are where there is maybe not enough of something. So that includes weakness, that includes lack of selective motor control, that includes things like ataxia, where there are missing or absent signs that are different from the hyperkinesis and hypertonia. So these are listed here from those three papers. Spasticity and dystonia, and rigidity, again, they mention in this pediatric paper because rigidity is clearly a very important syndrome of hypertonia, particularly in an adult context. Particularly, I was thinking about Parkinson's disease, but we rarely see it. I don't think I've ever seen it in children. Those of you who are paying closest attention will notice that dystonia both exists within the hypertonic category and also the hyperkinetic category, again reflecting the fact that there is an element of stiffness there, as well as a movement issue, as well as some other movement disorders, chorea, athetosis, myoclonus, tremor, tics, and stereotypies. Now, some of these I haven't spent great lengths to explain these in this talk. It's worth reading those papers, and I'd also note that there's actually quite some complexity about sometimes picking out the differences between some of these movements, and so there's definitely practice is required to really get to gain a huge amount of expertise in that. So I guess most importantly and most commonly, spasticity, which probably represents at least 80% of the movement disorder in CP, is defined by this group as being a velocity-dependent resistance of a muscle to stretch. So a passive movement where a passive imposed movement where the resistance to that movement increases with increasing speed and varies with joint direction. And there's also an element of this, the catch and release, which I'm sure you'll all be very familiar with, where rapid movement results in a catch, which is not present at a lower velocity, and also is overcome by ongoing movement through that passive range. I've described, again, or taken the descriptions that from this paper here in this next slide. Dystonia also is represented here as probably the second most common movement disorder. I think there's increasing understanding that dystonia and spasticity coexist in a lot of children, whereas most of the literature you'll read will still talk about dystonia being a small subset. But dystonia, like spasticity, it has an element of twisting and abnormal posturing, which again is slightly different from the presentation of spasticity. So we've defined here as an involuntary, sustained or intermittent muscle contraction with twisting and repetitive movements and abnormal postures. This graph might be useful for some of you. Dystonia and spasticity can both be stiff, but there tends to be movements at the twisting at the end of range of motion for dystonia, and the dystonia also tends to be variable in its level of tone, whereas the spasticity that tends to be much less variable. Spasticity is often present with other signs of what we call an upper motor neuron syndrome, so that will be brisk reflexes, sustained clonus. And we tend to see more contracted development in spasticity than in dystonia. I'd also note that, again, this is a gross generalization, that for children with pure dystonia, that often intellect is relatively preserved, whereas it's more common to see intellectual deficits and disability in those children with mixed conditions or spasticity. I wanted to move on now to talk about functional classifications. I'll talk about 3 of these 4. I've not explained EDAX there, but that's Eating, Drink, and Drinking Abilities Classification System, which is brand new and out in the last couple of years. The most robust of these and the most well-known is this Gross Motor Function Classification System, which I think is a core part of become a core part of learning about cerebral palsy over the last 10 to 15 years. These 2 other classification systems we'll touch briefly on as well. So the Gross Motor Function Classification System was derived in the early 90s, and it splits children into 5 classification groups based on their gross motor function abilities. These descriptions were derived from a group working out of McMaster's University in Canada, and the drawings were provided by the Royal Children's Hospital in Melbourne, and now have travelled around the world. Again, so the descriptions we have here are for children who are between their 6th and 12th birthdays. I've not shown you, but they're available through the website that I've shown on the slide here, that there are descriptions for children less than 6 years, and for children who are between 12 and 18 years. And indeed, these classifications probably remain consistent through adulthood as well, or at least early adulthood. So briefly, children who are GMFCS1 walk independently. They often have some small movement difficulties with their gross motor function, which sets them apart from their typically developing peers, and they are often endurance and or balance. Children who are GMFCS2 also walk independently, but with more substantial difficulties with endurance or balance. A key sort of figure here is that the children often are easily knocked over in busy spaces. So I often talk about the need to hold the child's hand if they're going to, for example, a railway station, and the need to hold onto a handrail when ascending and descending stairs. Children at GMFCS2 may and quite often might use a manual wheelchair for community participation reasons. The example I'd give is often for school excursions where fatigue maybe impacts on their ability to participate fully. Children with GMFCS3 don't walk for any substantial distance without a mobility device. They often walk with a mobility aid, commonly a posterior walker in most indoor settings, and then often use a manual wheelchair, either self-propelled or attendant-propelled for longer distances. Children with more severe mobility impairment, so GMFCS level 4 and 5, often use wheeled mobility as their primary mode of mobility. Children at level 4, particularly earlier in life, may spend some time doing walking in a more therapeutic setting with highly specialised walking aids, and they also have better trunk and neck control and are often able to drive a powered wheelchair for themselves. Whereas children at level 5 have very limited independent mobility and are highly dependent on attendant care really for all of their positioning needs. I guess one of the substantially good things about the GMFCS is that it's robust over time. So children do not change their GMFCS level or are unlikely to change their GMFCS level. And that includes really as well as children become beyond the age of 15 and into early adulthood. Often there are no interventions, including the interventions that I will describe later on, that will often increase or improve a child's GMFCS level, even sort of substantial neurosurgical interventions. And similarly, if a child who starts off in one GMFCS level seems to be declining over time, that's often a sign that there's an impairment which is causing a decline in their gross motor abilities that could be potentially reversible. So the GMFCS took the CP world by storm, and so there have been other classification scales that have helped clinicians easily identify children in terms of their manual abilities classification. So this here is to look at how children handle objects independently. Again, a 5-point scale. Children handle objects independently on levels 1 and 2. Level 3 needs some setup to help handle objects, and levels 4 and 5 require a significant support to handle objects. And communication. So similarly, levels 1 and 2 children communicate independently, both as an effective sender and receiver of communication. At level 3, they can do that with familiar partners, but not unfamiliar partners. And in levels 4 and 5, they're much more inconsistent with their ability to communicate. Both of these, the MAX and the CFCS, are freely available on the internet. So surveillance. So part of our usual program of practice is to surveil for either associated health conditions and impairments, or particularly musculoskeletal conditions where we know that that they can change children's health with time, or indeed their development. So I've listed these here that would be a standard screen at any rehabilitation assessment. We look for the development of contractures, for evidence of hip subluxation, scoliosis, leg length discrepancy, particularly in the context of hemiplegia, torsional deformities, special senses and hearing, particularly thinking about the preschool years and the development of fine motor function and language. Cognition, the development of pain, particularly in teenage years, mental health. We know that there's an association with mental health disorders and behaviour as well, which may impact upon their general health and well-being. I also wanted to mention hip surveillance in cerebral palsy. So this is an outdated document now. There's another version in 2012, which again is freely available through the Australian Academy of Cerebral Palsy and Developmental Medicine website, which is shown above. Hip surveillance was proven to be a useful intervention in the context of Sweden, and these are consensus guidelines that have been brought over to Australia that are followed quite widely around Australia to detect the presence of hip subluxation and lateral migration over time. Now, the risk of significant hip displacement, as defined by a migration percentage of over 30%, is actually linearly associated with GMFCS, and GMFCS is the strongest risk factor for abnormal hip development over time. There was a feeling historically that the hip subluxation was caused by by spasticity, particularly hip adductor spasticity, causing hip subluxation because of adducted hips. But actually, this is a much stronger association is about weight-bearing status. The way we measure simply screen for hip surveillance is through regular hip X-rays. Again, these are much more regular for those children who are GMFCS 4 and 5 than it is for kids who are GMFCS 1 or 2. And we use something called Reamer's migration percentage by measuring the amount of the ossified femoral head that is lateral to the Perkins line, which sits at the lateral part of the pelvic part of the acetabulum. And roughly, more than 30% of lateral migration places the child at an increased risk of developing more substantial hip subluxation over time, but also abnormal development of the hip, which may result in high rates of osteoarthritis as an adult. And this is a particular condition that we liaise with our surgical colleagues about for preventative treatment before that hip frankly dislocates. And again, so that we can see that risk is much higher for those children who are GMFCS 5. And really, this is not very commonly a problem for children who are function at GMFCS 1. Of course, we also see quite a high rates of scoliosis. Scoliosis really, from a neuromuscular perspective, is really only ever seen in severe CP, so those children who are function at GMFCS 4 and 5. The most common time we see this advance is during rapid growth during puberty. This is an S-shaped scoliosis that was present in a 16-year-old. And initial treatment for this, particularly whilst it's still mobile, is for seating modification. So for children who are in a wheelchair, that would be making sure that they have adequate lateral supports and their seating is adequate to maintain good pelvic positioning. For some children, when that's not possible, a thoracic lumbar sacral orthosis may be beneficial, but we often use lateral supports if that's sufficient. The surgical fusion is often offered when the degree of the curvature is more than 50 degrees. That can be either through an anterior spinal fusion or a posterior spinal fusion, depending on the size of the curve and the age of the child. And it's generally as much as possible deferred to the teenage years, because clearly most rods that are inserted do not grow and do not accommodate childhood growth. This young person went on to have surgical fusion sometime last year. So I want to talk now over the next 20 minutes or so about CP rehabilitation interventions. These include those that we, rely more heavily on our allied health colleagues for. So that would be strengthening programs. In New South Wales, strengthening programs are often provided through non-government agents external to the organisation. So it might be part of lots of children are incorporating this as part of their NDIS program now in New South Wales for those of whom that's available. Orthotics and splinting, which again is a combination of health and disability practitioners, and serial casting as a way of treating early contractures. I'll talk briefly about botulinum toxin A, as a frequent treatment for spasticity and dystonia, touch on oral medications, and then mention some surgical treatments for musculoskeletal deformity, and also for the neurosurgical interventions that are sometimes helpful for cerebral palsy. So generally, our interventions in cerebral palsy are designed, although they act at the impairment level, are designed to with goals at activity and participation level. Often they're designed really to improve independence for a child in terms of their function, but for those children with more severe disabilities, the focus goes on to ease of care and comfort for their carers. Having a knowledge of what growth does to children's bodies with cerebral palsy allows us to also try to avoid or manage the complications and deteriorations that are often seen with the condition. This is again a key reference from I think 2013, relatively controversial, but it has covered upwards 166 articles with 124 systematic reviews and 25 randomized control trials of interventions for children with cerebral palsy. Well worth a look. One of the aspects of this is a traffic light system. So Professor Novak has and her team identified green light go interventions where there was sufficient evidence to suggest that they were beneficial for treatment of cerebral palsy. These include botulinum toxin, hip surveillance that we just mentioned, the use of diazepam, selective dorsal rhizotomy, casting, pressure areas, fitness training, and constraint-induced movement therapy and bimanual therapy, the two major, modes of improving manual function in the context of hemiplegia. Also anticonvulsants for the treatment of epilepsy. She also identified lots of interventions where there was inadequate evidence, and I'm going to tell you this represents quite a lot of our practice, including some of the things that we'll talk about today, which I've tried to highlight in red: intrathecal baclofen orthoses, oral baclofen, orthopedic surgery. And finally, she also identified some interventions where there was good evidence that they were not helpful. These have included, again, not uncontroversially in the context of hip bracing, which is still popular with many orthopedic surgeons, craniosacral therapy, hyperbaric oxygen for the treatment of cerebral palsy, sensory integration therapy, these are therapy techniques, and neurodevelopmental therapy as well. So some of these are becoming more popular and maybe available through the National Disability Insurance Scheme at some stage in the future. There are lots of ways to think about the interventions that we'll talk about briefly. One of them is to split them up into global and focal and permanent and reversible, with pallidotomy, globus pallidotomy, which is an effective but seldom used now treatment for dystonia, being both focal and permanent, and selective dorsal rhizotomy, also very permanent, but lots of reversible treatments as well. Also think about them by their appropriateness for GMFCS. Now we use splinting, casting and orthotics across the GMFC levels as we use botulinum toxin. Oral medications tend to be more focused on children who have more severe disability. ITB and DVS really has only been used so far in the context of more severe spasticity and dystonia. And selective dorsal rhizotomy, as it stands, has been a treatment really for children with more mild gross motor function deficit, GMFCS level 2 and 3, and spasticity for spastic diplegia. We can also think about the timing of the intervention. So oral medications can often be given throughout the childhood lifespan. For pragmatic reasons, probably rather than clinical reasons, botulinum toxin often starts after 2 years of age. That's the age that it's available under the PBS, but we do give botulinum toxin if it's clinically indicated beforehand. It also happens to be the age that children who are ambulant start to appear to need it more. Hip release surgery and happens probably from age 3 and above, and those children with more bony surgery. Bony surgery tends to happen age 8 and above, particularly in the context of orthopedic surgery. Growth really will undo the benefits of or can undo the benefits of the surgery. So waiting until a child is older is often a way of avoiding other surgeries. Selective dorsal rhizotomy is often offered around the age of 6. And DBS and ITB, again, there are weight restrictions for ITB, but can be offered more sort of a wider age range. So I'll briefly talk about orthotics for the lower limb. So I guess we'll split orthotics into 2 parts. One of them would be functional orthotics, and a good example of that would be our ankle foot orthosis, which would be to improve our walking speed and or balance and or reduce the number of trips. That might be by through improving heel strike and with wearing an AFO. And some of them are about maintaining position in the context of growth. So that might be a removable night cast for that might be to prevent a knee contracture, or indeed an ankle contracture, or help with anatomical alignment after a surgical procedure. So the foam wedge that you see in the top photograph is a hip abduction brace, which was provided to a child following orthopedic surgery to our hips to maintain optimal hip alignment at night time. Botulinum toxin has become a mainstay of spasticity and dystonia treatments over the last 20 years at the Kids Hospital here. As all of you know, botulinum toxin blocks the release of acetylcholine at the neuromuscular junction, and at the current time, that's often used in conjunction with a burst of therapy to change and improve motor control, range of motion, and strength. There are dose limitations associated with children who are often, not always, but often smaller than adults. We tend to go up to dose range of about 16 units per kilo as total, with 400 units botulinum toxin, Botox as being our top dose. About 95% of our Botox currently is given with nitrous oxide sedation. Some units use general anaesthetic. We're increasingly trying to and helping older children wean themselves off nitrous and having the Botox injections without sedation where appropriate. I just want to give an example of some botulinum toxin goals here. So we might inject, shoulder adductors to help with swimming stroke in a child who is more functional, but for a child for whom their max is 5, that might be more caregiver goals to help with upper extremity dressing or axillary hygiene. We might look at spasticity or dystonia in the elbow flexors to help a child with more independent function to help them reach. But then again, that might help with upper extremity dressing for a child that's more severely affected. We often also inject wrist flexors, wrist pronator, and long finger flexors to help with grasp for children with more manual function, but also to help with upper extremity dressing, hygiene, and orthotic tolerance for kids with more severe disabilities. Again, I've got one slide here about oral medications. We'll split those into two groups. The ones that work primarily for spasticity, so I've mentioned Baclofen here, which is, I guess, our primary, the drug that we might prescribe most frequently, oral drug that we might prescribe most frequently. You'll all know that's a GABA B agonist. Diazepam, GABA A agonist also works, but children often attenuate to that, and it's often more sedating. Sodium dantrolene works at the muscle level, infrequently prescribed, but has been effective for spasticity use, but can cause liver impairments. So again, that's something that puts it further down the therapeutic choices. There are drugs that work more for dystonia than they do for spasticity. So levodopa is the obvious example, but we also use Bentexol, also trihexyphenidyl, which is antimuscarinic, and that's often a more successful dystonia agent, although the side effect profile, including mood changes and the dryness that it causes, can be prohibitive for some children. Clonidine and catapres can be an effective medication, adjunct medication. There's increased evidence for gabapentin, including some work done by groups in London suggesting this can be quite effective in improving children's quality of life. Tetrabenazine is a rarely prescribed medication, a dopa blocker, but can be effective in some children, but is also associated with severe mood changes, so it's not something that is very commonly prescribed. I just wanted to talk here about selective dorsal rhizotomy. So selective dorsal rhizotomy, so dorsal meaning dissection of the dorsal sensory nerve rootlets. So the way this works is by interruption of the reflex motor arc and dampening down of that and reducing spasticity. That's done through laminoplasty. So this is a photo of a laminoplasty in progress. Laminoplasty is from L2 to S1 and involves, of course, the laminoplasty and then opening of the dura to expose the chordae equina. The sensory nerve roots of L2 to S1 are identified, and the selective is a proportion of the rootlets that are dissected from that root are then cut using electrophysiological guidance. And so this is this is done infrequently. I guess Westmead is one of 2 sites that do this procedure in Australia, and we perform roughly on average 2 per year. The children, for it to be ideal candidates, have no contractures, have pure spasticity with no dystonia. This does not treat dystonia. Have good selective motor control and are strong and often young. To get the spasticity will go with largely go with this procedure, and often is profoundly reduced. But to get the benefit of it from a walking perspective, children need to have an intensive rehabilitation period, which is a year or up to 2 years for children who are functional at GMFCS3, and that's for them to learn the new motor programs and to overcome the inevitable weakness that actually this procedure causes. I wanted to talk briefly about intrathecal baclofen pumps as well, which we use for severe spasticity and dystonia. Again, this is not a frequent intervention. We might insert maybe 1 or 2 of these a year for children who are often at GMFCS 4 and 5 and for whom oral medications have not provided enough relief from their severe disability, and they are either having pain or severe difficulties with their daily cares. We go through a screening process before this is performed, including ruling out reversible causes of worsening spasticity, including hydrocephalus, and making sure there aren't other conditions that might be better treated through different strategies. We use a lumbar puncture and an intrathecal baclofen test dose as a way of screening children who might benefit from this procedure. They also have to have reasonable nutrition. In years past, the subcutaneous placement of the pump in a skinny child has occasionally resulted in erodement. That's been much improved with a subfascial placement now, but children really do need to be an adequate size for their body to be able to contain one of these devices, which is the sort of size of an ice hockey puck and a good couple of centimetres thick. The family also needs to be engaged and able to bring the child back for regular refills. The pumps either hold 20 or 40 mils of baclofen and need to be filled on at least a 3-monthly basis. So that's done using the bottom picture shows, for those of you not aware, this shows the device that programs the pump, and the top picture shows a picture of the intrathecal baclofen pump, and the central little silver button is where the needle is placed through the skin into the pump to fill the reservoir. There's a reasonable evidence base for ITB, particularly from a body structure and function perspective, that there's clear measures of reduced severe spasticity using the modified Ashworth scale. There's also some evidence of improved activity, including ease of care, quality of life, and individualised goals using Canadian Occupational Performance Measure and goal attainment scaling in those more severely affected children. I'll also very, very briefly mention, as I'm running out of time, deep brain stimulation. So deep brain stimulation is, there's an increasing evidence base for this. The evidence base has really migrated from our adult colleagues for treatment of conditions such as Huntington's chorea and for Parkinson's disease. And there's been a relatively strong evidence base for its use in primary dystonia in childhood. There is also some evidence for its use in secondary dystonia, so that's dystonia primarily caused by cerebral palsy, caused by damage. And there are some groups, including a group led by J.P. Lin and the Evelina Children's Hospital in London, who are leading the way in this as a treatment for childhood dystonia. We at Westmead, again with collaboration with adult colleagues at Westmead Adult Hospital and our colleagues in neurology, are placing probably about 2 of these again a year, and there's increasing collaboration about better understanding who DBS is useful for in a child setting. So I just wanted to, again, very briefly touch on, I guess, the last 2 or 3 minutes about the process of transition to adulthood, and I guess specifically transition from child services to adult services. This is clearly a prolonged process, and discussions of this in our practice usually begin in the mid-teenage years. I just want to highlight this is a busy time for many young people. They're going through big changes in puberty, identifying those that are able to, identifying their own independence, and often facing a few sort of major challenges, whether that be getting their driving license or their HSC and deciding what they're going to do with their future. There's also an active process there for the parents who often have been heavily involved with their children, you know, probably more than other typically developing children for many years. And so we do put work into identifying with the parents that process of letting go and letting their child become more independent. On top of that, we start to talk about what the adult systems might look like, and also start to reduce some of the support that they're given, particularly around botulinum toxin and sedation, with the hope that this will allow them, give them better access to adult services. For most young people, this process of actually gaining independence is not complete by 18 years of age, and is an ongoing process that continues into adulthood. Particularly, I'm going to tell you personally, I struggle with getting most 17-year-olds to understand the process of goal setting, and I guess reflecting on that, it's a difficult concept to understand as a teenager. And for some children, young adults, this is complicated by their intellectual disability and whether their functional potential is going to allow them to gain that independence, in which case that transition process is still heavily reliant on their primary carers. I just wanted to acknowledge Dr. Mary Claire Waugh, who provided many of the photographs, and as has Jenny Lewis, one of the physiotherapists on our team, and our members of CPMD, who've provided photos and other information that I've used in these slides. My last slide, again, is just a list of key references. The first 2 references are great 3 to 4 page reviews of cerebral palsy from more of a rehab perspective. I've mentioned those movement disorder papers as well, and there's a review of drug treatments used in dystonia, again from the Archives of Disease in Childhood. There are plenty of good resources on the GMFCS, and also thinking about the ICF model from a childhood perspective, also on that CanChild website at the bottom. Thanks, Terence. I think that's my last slide.
Thank you, Simon, for your time and your presentation.
Do I stop sharing my screen? Or?
Yes, so if you just want to stop sharing.
Sorry guys, I hope that was...
So all microphones have been unblocked. Does anyone have any questions? I don't think anyone has any questions, Simon, so thank you again for your time. Sorry?
I'm very happy to, if people have got questions that they want to ask by email, I'll point out my email address was on that first slide, so I'm very happy to hear from people with questions or comments. Thank you, everyone. Have a great day.
Thank you.
Yes, bye. Hang up. Hang up. I'll hang up. Thank you.
Thank you. The next presentation will start shortly.
When successful surgery was given to deal with the back lesion and the neurological lesion. Holter designed his one-way valve for CSF shunting in 1952, and that again made an enormous stride forward in survival, and it increased from 10% survival in 1956 to 10% mortality in 1985. And things have probably got a bit better since that time, but not dramatically. so. So just a few definitions. Spina bifida occulta is that associated with bony elements only. It can be associated with a myelocele or a myelomeninger which is the common one where there's bone meninges and spinal cord. But there can be also lipomas leading to adhesions and pressure, diastematomyelia with splitting of the lower cord, and myelocystocele. When you do MRIs, then you can find these associated with pressure effects. So that's a bony lesion and of occulta, and you can see the lack of a spinous process present there. So that you go from spina bifida occulta, where there might be a lesion on the skin, a hairy lesion, to meningocele, which is relatively uncommon, to the more common myelomenincele, where there are also issues with the neurological lower spinal cord. Don't forget that we tend to concentrate largely on the spinal effect, but remember it's often associated with deformation of the upper spinal cord or upper brainstem into the below the foramen magnum, and that leads to potential pressure effects as well. So what we've gone to, there's about 1 per 1,000 live births, of which 2/3 have myelomenincele. There is been a recent drop in terminations recent drop in incidence due to terminations to a greater extent, and folate treatment has been found to have some degree of success, but only a relatively mild degree, because most of the folate is needed very early in the pregnancy, often before pregnancy has been diagnosed. And there is a slight familial increase in incidence. You look at the, this is up to 2006, looking at the prevalence of spina bifida. There has been an improvement from a high of 5.22 to round about 3 and 3.3 or so in the mid noughties, so to speak. So that it's still a relatively common condition, and there hasn't been a great deal of change recently. So if you look at that, unfortunately, the percentage is not shown in the first slide. Around about 50 to 90% reach adulthood. These days, it's very much closer to the 90%. These are figures from Webb's article, which I would strongly suggest if you want to know more about. He is one of the major authors, and he produced this paper in 2010. Therefore, there are more adults with spina bifida around than there are children. We tend to think of it as a disease of children or a condition of childhood. It's really not the case these days because of the greater survival. There's been an explosion in the last few years of published papers regarding adult spina bifida, but there's relatively little even now in the over 40s, and this is becoming quite a significant group to deal with. And it's interesting that the treatment is somewhat different in adults than it is in children, and there are different issues associated. So if we look at a study by Roach in 2011, he retrospectively looked at a cohort of 84 individuals looking at social, cognitive and physical disabilities. In other words, all of the major issues there. Minimum age at follow-up was 20 years, a mean of 31 years, and even going up to those at 64 years, remembering 64 years brought it back to the mid-1950s in terms of birth. 42% had normal IQs. We tend to think of the issues being really very severe, but the issues were quite severe, but really there are quite a number of people with quite high functioning cognition status. 30% needed a neurosurgical shunt, and certainly one of the issues that comes through strongly in terms of positive outcomes is that if you don't need a shunt, then you're far more likely to do well from a cognitive and a general perspective. 46% had regular education. This is a US paper, and therefore looking at college degrees, but if you actually look at that's a relatively small percentage of the overall population achieving college degrees. And the other issue is that a very large percentage were unemployed, even though 42% had normal IQs. In terms of living independently, 30% did that, 23% were married or divorced, and 9 normal offspring, meaning that if you have a child, then there's by no means certain that you'll have a child with spina bifida. Significant numbers drove, most of them, apart from the higher level issues, dressed themselves and shopped independently. 31% had thoracic neurological level, although it is really important to be aware that you can't make nice cut-offs in terms of spinal levels like you can in a spinal cord injury group. And there's quite significant variations in sensory and motor levels. Smaller number were at the upper lumbar areas, all used the wheelchair except one, although if you actually look at children, that group, much larger percentage were using a wheelchair, but they found, a smaller percentage used the wheelchair, but as people got larger, they put on weight, they grew in size, then it was much more energy efficient to use a wheelchair. 78% used a wheelchair at least part-time, even of the lower lumbar levels, and if the sacral levels, about a quarter, and all of those walked. Although there was a significant problems with skin pressure ulcers, and if you're looking at this group of under 64-year-old people, 4 requiring major extremity amputations is a very large number indeed, as well as partial foot amputations due to sensory loss and pressure areas. So in terms of the life issues, we have to realise that we're dealing with habilitation, not rehabilitation, and it's really extremely important to treat this group in a different way, those presenting with acquired brain injury or spinal cord injury as adults. There's a need for lifelong management, and I strongly feel that lifelong management should include specialists in treating this condition, and I think that rehab physicians are extremely well able to do this, provided they have interest in training and time. GPs need to be very much involved in terms of the longer-term care for all the other non-specific things that happen to this group of patients. And there are social consequences both early and late, especially as people age. Their parents who had previously been very much involved in their care become less able to do so. They may not be able to transfer in the way that they were doing earlier. They may not be able to provide the same care options in terms of showering and dressing, etc. They may develop bad backs themselves and not be able to care for their adult children. There's very much a lack of appropriate social outlets. Transport issues are quite considerable. If you need a maxi taxi, even with half-price taxis to go places, then that is a large financial burden. And really, this group of people doesn't have a great deal of extra money to be able to throw around. So if you actually look at this group of patients, and I think they're from Oakeshot's study in the early 2000s, if you look at the major groups below L3 from the thoracolumbar area and above E11, you can see that in this group there is quite a sizable percentage of thoracic spina bifidas, but very much larger percentage of those with higher lesions had died. But there is a significant issue in terms of CSF shunting, and those with the higher lesions to have increased need for CSF shunts. Community walking was really for those below L3. As you can see, the above P11, two of those cohort of survivors only were able to live independently, whereas 14 of the 24 with much lower levels. And in terms of driving in cars and open employment, you can see the differences there as well. They need to go into hospital, and quite frequently they need to go in. There was a comparison done with PBI, cerebral palsy and spina bifida groups. If you look at the Kinsman and Turing figures from 1996, the group with spina bifida had 3.6 admissions in 11 years, which for a relatively young group is a very large percentage. And they calculated that 47% had preventable causes of hospitalisation, and so it's really very important to get people to be able to self-manage, or if that's not possible, make sure that their parents or carers are able to self-manage. In 2006, looked at a group of adult patients in Canada, and they found that almost a fifth of those had been hospitalised in the past year, which is really, again, an inordinate number, and quite a number of those patients had multiple hospitalisations. And therefore, there's the issue of costs, and not only that, the people who come into hospital tend to be readmitted in relatively short time. Now, moving on to discussing an issue that's really very important, and that's the transition of spina bifida patients from the children's hospital systems to the adult hospital system. And frankly, if this is not well done, there's a high likelihood of complications occurring for those people to be move out of tertiary care, to be followed by their GPs who, whilst how well-meaning they are, they really have major problems in dealing with this group. They're very time-consuming. I normally take at least an hour to see a first patient used to take an hour in my clinic, and that was associated with quite a lot of input from the allied health and nursing staff as well. So Sawyer is professor of, or was, I'm not sure still is, but was professor of adolescent medicine at Royal Children's Hospital in Melbourne, and did a paper on transition highlighting how important it was in 2010, and really sort of had major issues around the repercussions around the world. So I would think if you're wanting to pass exams or OSCEs, etc., it would be very useful for you to read that. It's a relatively short paper. So we're getting increased numbers with increased survival. And in the paediatric clinics, they're often multidisciplinary with both paediatricians, developmental paediatricians, or paediatric rehab specialists these days. Often neurology is very much involved, neurosurgery, orthopedics. Whereas in coming to the adult world, there are very few multidisciplinary clinics around, and basically for people who have orthopedic, urology, neurosurgical and rehab needs, they have to go to each of those clinics in turn. So it's really very important for there to be good communication between each of the people. It's not just a transfer. It needs to be a transition, and there needs to be engagement on both sides, pre and post the transfer, such that there is an uninterrupted healthcare given. Because this was not being done, and because the poor paediatricians were looking after people in their 30s and 40s and didn't want to do so, and felt that they were not the appropriate people to be doing so anyway, that the Victorian government in 2000 set up 4 clinics at St Vincent's for people with cerebral palsy, Royal Melbourne Hospital for Spina bifida, Monash Medical Centre for both, and Bendigo for both, to look at making the pathway from the paediatrics to adults much more appropriate, to consolidate expertise, to provide a holistic model of care in association with the GPs, to have much better information sharing between adults and paediatrics, or more the paediatrics than adults. And that certainly has led to better care for the majority of patients coming through. But unfortunately, the difficulty has been that we've also almost been too well done for, and so that there are now significant waiting lists. There has been always some difficulties with retention of suitably trained staff, recognising there are relatively few of these. There is certainly some difficulties with specialist access to urology, neurosurgery, and orthopedics. And probably I think that there's been a lack of emotional support for patients, and so that this has led at Royal Melbourne Hospital to, in 2013, we set up a system of transition from Royal Children's Hospital to Royal Melbourne Hospital for the group of patients with spina bifidas. And so that We, at that stage, had 130 active clients, of which 86% were aged under 50 years. Some of these patients also had diagnoses other than spina bifida. There was a large group of patients aged from 18 to 29, and 75% of the patients that have attended the clinic have had spina bifida. At that stage, there was a clinical nurse consultant who acted as coordinator, who had experience in both urological and bladder issues as well as skin issues. There were a number of rehab consultants working on a regular basis with the group of patients. There was an experienced physio and occupational physiotherapist dealing with neurological disability, OT very much dealing with seating issues, skin problems, social worker who dealt with the multitude of social issues associated with this group of patients. There was an allied health assistant and, very importantly, a rehab engineer, because this group of patients, as we know, took up a lot of time in terms of dealing with wheelchair problems. There were strong links with the Royal Melbourne Hospital Continence Service, and via that, because the geriatrician who worked in that service also had a lot of expertise in dealing with younger patients with multiple sclerosis, and he also attended a urology clinic at Royal Melbourne Hospital City Campus once a week. The chronic wound chronic wound clinic was also co-located. We have continue to have an orthotics and prosthetics department in terms of pressure issues and orthotics, and that we have a rehab medicine outpatient clinic. So we actually, I'll go back. We had a transition event on that day where the paediatricians from Royal Children's Hospital met the clinicians at the Royal Melbourne Hospital Royal Park campus. On that day, the coordinators were there, and we had a comprehensive case conference and handover, remembering that this group of patients is always has had a very complex past history, and it's really very difficult to get that into a page and a half of letter of transfer, and extremely time-consuming for the paediatricians. And being there on the day, they were able to give a handover of the multitude of urological and neurosurgical and psychosocial issues that were present with this group, and we were also able to let them know what we weren't able to achieve. The patients, whilst we were talking, were given a guided tour of our rather elderly. This is the old Royal Park campus there, which is rather a pleasant facility. But we do have rather more updated facilities than that. We had 6 transferring patients, 14 family members and friends experienced the tour. And then at the end of that, the patients for Royal Children's were introduced to the staff by the ICH clinicians, and so that a familiar face could be seen at the first consultation to make sure that people turned up for their first consultation, which is not always the case, and so there's a potentially quite a large drop-off between paediatrics and and the rehab clinics. Okay, so just to talk about some of the issues that you may not have heard of before that are really quite common, and really the major reason that we want to look after these patients is to make sure there are not ongoing complications, and to recognise, if there are, to recognise those at an early stage. Latex allergy is the first thing that you need to ask about if you encounter someone with a spina bifida. It's quite common in this age group, much more common than in the general community. And you don't want to have the discomfort of learning about latex allergy after it has occurred, because it can lead to fairly straightforward contact dermatitis, allergic rhinitis, as far as quite severe bronchospasm, angioedema, and certainly it used to be an issue that occasionally cropped up in the operating theatre, but not only just in the operating theatre, with anaphylaxis, and certainly some of these people have had to have pens provided for them with some sympathomimetics. The incidence hopefully might be reducing because there's less tendency for early and multiple surgical interventions, especially abdominal surgery interventions, which certainly have been in the past associated with latex exposure. And it comes in contact skin, mucous membranes, eyes, genitals, bladder or rectum. Remember those two as well in terms of catheterization. There is a certain cross-reactivity with certain foods, although it tends to be somewhat less. I've already talked about the multiple intra-abdominal procedures, the change of gloves now to non-latex gloves to protect surgeons have also protected their patients as well, and it can range in severity from minor irritation to anaphylaxis. And just saying again, it's the first question that you need to ask anyone with with this condition. So talking about cognition, which is a really very important thing. I haven't got too much on it here today, but I really want to stress that these patients, or sizable numbers of these patients, have major issues with cognition that are at times quite difficult to spot. They tend to have problems with insight. I should say that the cognition problems are very much associated with neurosurgical issues, with the insertion of shunts, with shunt infections, or especially multiple shunt infections, or malformation or malfunctioning of the shunt. And so that really, again, those are the first questions that you need to ask with someone coming in. Do you have any shunt? Have you had any shunt infections? When was the last shunt infection? Have these required hospitalisation, or it goes without thinking that they have had hospitalisation? Have you had any shunt dysfunction? Has the shunt needed to be replaced on a number of occasions? So they have problems with insight. They have problems with executive functioning. They tend to have a verbal proficiency above performance proficiency, and you've probably heard of the cocktail party syndrome, where these patients can chat away on insubstantial matters quite well, But if you then want to get them to actually act on things, that's much more of an issue for them. They tend to overestimate their competency in regarding that. There is a tendency for them to be very over-reliant on parents, which you can get away with as children, but is not a good thing when you go through puberty and reach adulthood. And even if people are managing quite well, there can be tendency for some subtle cognition issues. So the neurosurgical issues has there been shunt dysfunction, which is not always quite all that easy to see. A lot of these patients have got ventricular enlargement due to hydrocephalus prior to birth, and so you can't just go on whether there's ventricular enlargement, but you need to look at other things, in clinical things, in terms of looking if there is a major issue with shunt dysfunction. There can be differing symptoms, and those can be quite difficult because some of them may be neuropsychological difficulties, and it's really very important to listen to parents. They are the people that will pick up subtle difficulties in cognition at a far earlier and greater stage than anyone else is. And so don't play down those difficulties. If the parents, especially in the higher level adults or young adults, complain about changes in cognition, think about that very significantly. There certainly can be improved functioning following shunt revisioning in visual and verbal memory, motor coordination, attention, cognitive flexibility, at times bladder as well. But just because there is on a CT or an MRI that there's been a shunt that has broken down doesn't necessarily mean that it needs to be repaired, and that there have been a number of people that I've done MRIs for varying reasons, and found that they've had shunts that have not been functioning for 10 or 15 years. So don't immediately think they need revision. Again, with syrinx, it's not uncommon on MRI, but a lot of these are not necessarily symptomatic, and just exactly what happens in the long term, we frankly don't know. Going on to urological involvement, extremely common, as one might expect, with no matter what level that you're likely to have motor or sensory involvement of the sacral nerves. Poor compliance, poor contractility, and a tendency to therefore require some emptying of urine at an earlier stage, but with increased residual urine due to obviously partial or complete denervation of the bladder. In a significant number, there is internal sphincter incompetence, but there also is at least partially functioning external sphincter capabilities, and there can be a link with detrusor sphincter dysynergia, and so there's a need to, if you've got concerns with regard to that, you need to be checked that over at an early stage and to get urodynamics done. So the goals are like with every bladder issue is prevention of upper urinary damage and achievement of continence. So the damage is done generally by either infection or the psychourethral reflux and hydronephrosis. There can be a diffusive sphincter dyssynergia. There can be structural abnormalities also to a much greater extent than in the normal population. There is a need generally, although this is somewhat question regarding upper tract imaging to look for early signs of hydronephrosis, to alert you and to make you make sure that there isn't further upper tract damage being done. There are long-term complications of ileal conduit diversion, which was a very common surgical treatment in years gone by. There's obviously frequency of renal deterioration. There can be stones formation in the kidney as well as in the bladder, and pre-malignant changes in colon cells due to contact with urine, and commonly as well as the problems of pus damaging the bladder and leading to an increased risk of urological cancers as well. And again, to question the need for urodynamics. Intermittent catheterization only developed in the 70s, and therefore the old complications of renal failure are very much greater in those of older age group, and so you need to be questioning about that, and do they have urinary diversions. There is still present issues with renal failure, although this is significantly less in terms of death. Interestingly, survival on dialysis and transplantation is quite good, and I've seen a number of patients who've gone on to have dialysis and transplantation. I've talked about PCD, adenocarcinoma, and SCC, and so there's bladder augmentation that needs to be looked at in terms of a recent need to have that done on a regular basis. Some of the newer procedures, we frankly don't know the longer term consequences, and so that's something to be looked at in the longer term. Somatic autonomic reflex pathway microsurgery has been done, although this is not a common thing, and I don't think we have had any at Royal Melbourne in the time that I was there. Clean intermittent catheterization plus or minus anticholinergics are really the standards of care. Make sure that if you're doing a grade A manoeuvre that pressure is not too great, causing hydronephrosis. There's the issue of long-term antibiotics in this group, as with spinal patients, because the bladder has poor compliance. There is a quite common bladder augmentation being required, and that has the issues of malignancy as talked of at a later stage, and problems with diversions, for example, the use of the appendix in a Mitrofanoff procedure, and that we again don't know the long-term effects of these. Have I got anything here? Just the Mitrofanoff procedure is where the appendix is upended and used as a continence diversion with a stoma that can be much easier able to be catheterized both by patients and by family members. So that provided it works well and there are no stonal problems, then it's much easier for people in going about their normal daily busy lives to be able to put a catheter into the abdomen than to do it through the perineum. So enterocystoplasty is bladder augmentation is a common procedure. It has quite a significant complication rate, and it tends to increase as time goes on. If people have had stomas fashioned from stomach, as occasionally happened as an early stage, there's a much greater risk of malignancy for those with cecal bladder augmentation. So that's the standard procedure these days. People require long-term urological care, and so that they need to be followed up with urology, especially if they've had any operative treatment. Protection of the upper tract is very important. Sexual functioning is important as well. That there is a need for generally ultrasound follow-up on a yearly basis, although that can be tailored to individual patients. And there's really, bacteriuria is a bit like on the spinal situation. There's some questioning as to the appropriate treatment for that. I won't talk about Mitrofanoff principles again because of time issues, but stenosis of conduit is quite a common issue. Again, urinary stones, whether there's been increased in after Mitrofanoff or just that's still not entirely sure. Sexuality obviously becomes a greater issue as people go through the menarche or with puberty. Girls tend to have an earlier menarche. There is certainly a lower fertility rate for males. There are difficulties with females to carry children in terms of the just general abdominal contents, the need to be in wheelchairs, etc. There are certainly an increased risk of UTIs. There are marked psychosocial difficulties both with females and especially with males. And certainly it's been shown that young adult men with spina bifida, especially myelomeningocele, begin sexual activity late. There is potentially some issues of neuroendocrine functioning in spina bifida. Menstrual hygiene is a major issue during the menarche, especially in girls with high-level lesions. There are clearly issues in terms of physical and continence issues associated with sexual activity. Lubrication tends to be reduced in females, and there are orgasmic issues, and with males, there retrograde passing of sperm is quite a common thing. And so, interestingly, as opposed to the males, there is normal fertility in females, and therefore, and relatively at times behaviours that are at risk and therefore contraception and protective behaviours need to be discussed at an earlier stage. That 4 to 7% risk of spina bifida in offspring has been quoted, although it's questionable as to whether it is that high. I've already talked about the surprisingly high rate of at-risk behaviours, and 75% of males, according to GAME in 2011, have erectile dysfunction. In terms of the neurogenic bowels, 20% have normal bowel control. There is impaired rectal sensation, impaired sphincter function, altered and slowed colonic motility, possibly due to gastrocolic or lack of gastrocolic reflex. If you've got a bulbocavernosus or anocutaneous reflex, continence can be very significantly improved. So the aim is to become continent and to be able to time toileting so that you don't spend gross amounts of time on the toilet. So the aim is to stimulate a reflex relaxation of the internal sphincter before the rectum becomes full. Use of stool softeners, suppositories, digital stimulation. It's quite surprising the number of adult people with especially high-level lesions that have manual removals done by their parents, in general terms, their mothers. And a MACE colonic, MACE antegrade colonic evacuation procedure is the use of the appendix to be joined up to the cecum and as a stoma, so that there can be antegrade colonic washouts rather than the normal retrograde colonic washouts. It certainly makes some sense there. It can be some certainly some ease of evacuation of the bowel, but again, it's a relatively recent procedure, and we don't know about the long-term effects. Up to a third have fecal incontinence of small or large degree. And so that, like everyone with a spinal lesion, you have to have an individual bowel program. But even those, according to Webb in 2010, the 38 to 46% only had a regular bowel program. And so that it's something certainly as we look at patients coming into the clinic, there is really a major need to go over bowel programs. It's been going since 1990. It's generally started with the MACE in the paediatric wards. The tap water, saline or soapy water have been used generally without metabolic sequelae, but you need to monitor renal function and electrolyte loss, especially sodium loss and free water absorption issues. The complications are not infrequent, and revision therapy is often required. Skin breakdown is a major issue with rehospitalisation, sacral areas, bony I've just lost it's certainly not provinces, but prominences. I think it's, I didn't realise it was self-corrected, especially over the feet, especially if their feet abnormalities associated with Charcot joints, especially ankle and subtalar joints. there can be joint pain there if sensation or partial sensation is present, and there can be late development of syringomyelia. So skin, need to look at skin every time you see a patient. Don't just rely on the patient's statements regarding that. Lymphedema is extremely common, especially with wheelchair users and upper level spina bifida patients. It can be associated with trauma, it can be associated with cancer, wounds, higher level, and mobility status, as I said, especially wheelchair users. And according to Garcia in 2011, it was 100 times higher than that present in the general patient population. So be aware of that. Pain management is a significant issue. Nociceptive, it can be low back pain, pain related to arthritic or Charcot joints, overuse injuries, especially in wheelchair users or crutch users, which basically means most of the people. There can be a component of neuropathic pain also in this group. I'll just mention that it's called syndrome at a later stage, and because there's a link with osteoporosis, there can be acute fractures, and is in a spinal population the possibility of fractures occurring without a great deal of obvious signs. So some of the musculoskeletal, so again, 22% of this cohort study experienced nociceptive pain, often low back pain, and 10% had neuropathic pain, and interestingly more prevalent in patients without hydrocephalus. One wonders if cognition may be having an effect there, and in older patients as well. So it may be something that we'll see more as time goes on. Interestingly, it was not associated with the completeness of the injury. Okay, the musculoskeletal effects, hyposcoliosis, very common and can progress even in adults and even with fixation during the childhood or adolescent years. It's associated with osteomyelitis and significantly increased risk of high-level amputation as well as partial foot amputation, chronic pain, overuse injuries, I've already mentioned, low back pain due to a myriad of causes, and some, in terms of especially the ambulant patients, there's a need for lighter and stronger orthoses, especially in terms of weight gain. There is hip flexion deformity. There can be subluxation and dislocation of hips in high-level lesions, although to a lesser extent than in cerebral palsy. Obviously, flexion contracture of the knees is potentially common in wheelchair users. 85% of children have feet deformities. Lack of sensation can lead to issues of skin care, and it's really important to be aware of that potential risk and to check out the feet. If people have flexible feet, they're much less likely to have skin deformities or feet deformities or skin care issues. Fractures is, as I've mentioned, occur in 20% of children, especially the proximal and distal femur, with difficulties of diagnosis, conservative rather than operative treatment at all age groups. Osteoporosis, excuse me, I'll just have a drink. Quite a common thing. What to do about it and how to measure it is quite a issue because the DEXA scan of the spine is unreliable. These patients lack the bony elements and may have joint contractures or implanted hardware. And if it's present in the upper limbs, is it really associated with lower limbs or not? Orthotics, I won't deal with that. I want to quickly go over in tethered cord because it's certainly something that you need to know about. Patients do know about this, and you need to appear knowledgeable to gain people's, especially parents, trust in you. It's a stretch-induced disorder of the spinal cord where the base of the cord is stuck down and there is pressure transmitted along the cord, especially in the adolescent years when there is growth of the vertebral column at that time. And so it tends to present mostly in the adolescent years, but it can also tend to occur at times in adulthood. Certain activities, flexing or extending, especially flexing the lower spinal column, put additional tension on the spinal cord and often worsen symptoms. I have seen this in a high-level basketball user who had to give basketball away due to significant low back pain issues. The treatment there was conservative, but I'm unsure as to what's happened in the longer term. We tend to diagnose by looking at flexion of the lumbosacral spine and expectation of that there will be increase in symptoms. It can present late and insidiously with progressive gait disturbance, muscle atrophy in either sort of groups or in the whole of the lower limb. There can be neurological changes in terms of loss of reflexes, but that is often the case. Reflexes are not present in the first place, so it's difficult to judge that. Lack of sensation in sacral dermatomes, especially when there has been no issues previously. There can be sphincter disturbances, gait abnormality, and pain in the gluteal or perianal and pelvic areas. Diagnosis isn't straightforward, but generally use MRI as the diagnostic tool, and if there's progressive neurological involvement, as one might expect, then the treatment is surgical untethering. Triggers can be falls or trauma. Vaginal childbirth is associated with that. And pain is really the best treatment or has the best effect in terms of surgical treatment. Ambulation and bladder function may or may not improve, unfortunately, in the shorter duration as one might expect from onset to having surgery. the better the outcome is likely to be. So just getting on to issues that become greater in adult life. Pain is an issue, intimacy and sexual well-being, obviously. A large percentage of these patients are obese, and they have the long-term consequences: skin, cardiac, pulmonary. Obviously, pregnancy becomes an issue for females. Depression is at an increased risk in this age group, and interestingly enough, there is an increase in health risk behaviours in smoking, ethanol, substance abuse, and sexual high-risk behaviours in this group compared with others. 35% are obese, and exactly how you measure that, skin folds, etc., not all that straightforward. Obviously, just weighing this and having the capacity to weigh the wheelchair at the same time is really a major issue. In the Netherlands, 20% of this group smoke. There were major problems of skin issues. Pulmonary embolus is increased in this group, although not to a dramatic extent. Hypertension and risk factors for cardiovascular disease are very much increased, and so that as this group in ages, they're going to get cardiac disease and tend to get it at an earlier stage than the normal population. And don't forget about sleep apnea, both central and obstructive sleep apnea, especially associated excuse me, with obesity. Obviously, there's an increased risk of diabetes and insulin resistance, increased risk in cancer, especially in bladder augmentation, and one would wonder, given their risk behaviours, an increase in STDs. A relatively lower number are in open employment and schooling. They tend to be part more than full-time and with associated transport issues. There is a small increase in epilepsy with a higher proportion present, but nothing like the same proportions as in cerebral palsy. Certainly the social isolation and poor socialisation with other peers are really very, very major issues when this group leaves school. And there's the omnipresent overprotective parents that are really quite difficult to deal with. Getting reasonably close to the end, suicide isn't increased, perhaps somewhat surprisingly, although cognition is towards the lower end of the WACE. Certainly better if not shunted. And the other cognition issues make it far more difficult for these group of patients to achieve self-maintenance and independence, and much more difficulties weaning from the parental home and moving to paid employment. According to Webb, the major issues for research are in terms of sleep apnea, given its issues, longer-term ageing, both in this and in the spinal cord issues, those associated with ventricular shunt functioning, and how important that is, especially as adults, because some patients are far more reliant on their shunts as if they're young. What happens in the natural history for the over 40s, sexuality, obesity and diabetes, cardiovascular risk, and osteoporosis. So there are significant issues associated with stigma and lack of social inclusion, reduced social support, and the patients tend to have low self-esteem. And as previously, don't overestimate their self-management skills, because you do it at your peril. And one of the major issues in transition is to let the patient and or carer know about the adult healthcare system. So this is my last slide. You'll be happy to know. The other issues that are really, I think, very important are the cognitive deficits and self-management, and that the need for social worker involvement there, overprotective parents and the difficulties in weaning the child away from the parents and the parents away from the child. Pediatrics not letting go used to be an issue. It certainly hasn't been an issue from my perspective, especially with the close liaison. Regular meeting and sharing protocols between services and to build up a transition. One of the things that the adult urologists don't tend to do a lot of the procedures that the child urologists do, and so it's really best to have a good liaison between the child and adult proceduralists, and a very good handover. And again, the urological surgery procedures are really quite unusual, and I would also say some of the neurosurgical procedures, and tethered cord being one of the major issues associated with that. And I will leave it there. I'm not sure if anyone has questions.
Yep, thank you, Geoff. Does anyone have any questions? So it appears no one in the further room has a question. And no one.
I'm sorry, it was a bit long-winded, but a fair amount to get through, and I realise it was rather didactic, and I apologise for that.
That's right. Thank you so much for your time today, Geoff.
Okay, thank you. Bye.